Mm, yes, sir.
Adi Nazar.
Yes, sir.
Good. Okay. So there was a confusion. Some people thought that I have covered schizo-obsessive. I mentioned it somewhere in my one of my presentations about schizo-obsessive that an exam situation it's preferable that you should not mention about it. But of course, in clinical setting, it is an important thing. And when you are seeing patients in day-to-day clinical practice, you see many patients who are having actually schizophrenia and they are having OCD as well. And sometimes intractable, complicated OCD is also there, which is confusing whether it is OCD or psychosis. And then there is diagnostic dilemma as well. So I thought that, okay, fine, let's cover up this topic, see how things can move, and then maybe the next time there was again one more topic, opioid uh, treatment strategies or agonist. So next time फिर वो cover कर लेंगे. Okay, so schizo obsessive, Bismillahirrahmanirrahim, OCD, OCPD or schizo obsessive. Things are complicated. एक कोट है, कहीं से मुझे नजर आया, मुझे अच्छा लगा. आदम की गफलत असल में खुदा की मसलहत थी ताकि इंसान को
Sir,
ये
I
सिखाया
think
जाए.
I can't see the screen.
You
I
cannot see
can,
the
or
screen.
okay, I can. Sorry, I can see it. There was some problem with my connection. It's fine, I can see it.
Okay, so should I continue?
Yes, sir. Sorry.
Okay, no worries. So कोट है, आदम की गफलत असल में खुदा की मसलहत थी ताकि इंसान को ये सिखाया जाए कि गलती फितरत है, तौबा कुदरत है और माफी रहमत है. So we all do make mistakes, and if you are confused about the diagnosis of schizophrenia or schizo-obsessive, again you have to correct yourself and you have to move forward with the things. So I thought that maybe when we are talking about OCD, so I don't want to go for the diagnostic criteria for OCD because that is out of again scope thing. But when we have to present OCD, some of the differential diagnoses include Asperger's syndrome, OCPD, kleptomania, Sydenham chorea, Tourette syndrome, trichotillomania, body dysmorphic disorders, hypochondriasis, anorexia nervosa, bulimia nervosa, delusional disorders. All of these are part of the ORCD, जो ICD 11 में इसको मैं नेम दिया गया, obsessive compulsive related disorders. So these are various things. So you have to keep in mind that if even if the patient is presenting with simple obsessive compulsive disorder, you have to rule all of these out before committing that this is OCD. Sometimes some differential diagnoses are difficult to again assess in exam situation, like OCPD unfortunately gives lots of complication. You need to have an account, detailed history, past events, onset, blah blah. So lots of things needs to be assessed, and because of the shortage of the time in exam, probably we are not able to do so. But in clinical settings, when you do have time and you are assessing people with OCD, you should assess OCPD, kleptomania, Sydenham chorea, Tourette syndrome, trichotillomania, body dysmorphic disorders, hypochondriasis, anorexia, bulimia, delusional disorder, and Asperger's. This is very unfortunate that most of the Asperger people, they flourish up to the college level. They are fine in academics, and then suddenly there is a change and they are stopped grooming or becoming too well, uh, again in terms of their future profession and careers, but they are otherwise appears to be normal people. They do have some obsessive symptoms, and sometimes it's very difficult again to understand, is it OCPD, Asperger, or OCD? So some of these things are confusing, but diagnostic dilemmas. And the treatment, of course, is different for different types as well. Like if you are talking about Asperger's, as such, there is no drug for Asperger's syndrome. It's more like behavior therapy, cognitive therapy, social supports, and other non pharmacological strategies. But definitely, the drugs can help some of the people who are having Asperger's syndrome. The treatment for delusional disorder, of course, is antipsychotic rather than SSRI. So, if OCD is presenting with delusional disorder and you have come up with this phenomena that this is delusion rather than typical OCD, then of course the treatment is different. In OCPD, again, the treatment strategy, as the name indicates, is different. So all of these disorders, they have different
लिंक भेजा था
interventions.
किसी लेक्चर का
And when interventional strategies,
था चीजो इफेक्टिव डिसऑर्डर इस तरह का कोई लिंक था
sorry, couldn't understand. Somebody saying something? No? Okay. Okay. So you have to understand these all OCD types and spectrum disorders and comorbidities because the intervention changes from each diagnosis from one to another. That is important to keep in mind. And of course, sometimes, as I mentioned, it's not possible to assess them in one sitting for all of these things. Sometimes it takes us time. Maybe we have to go for investigations. Maybe sometimes we have to go for some psychometric testing. And of course, repeated serial mental state examination give us a clue, and revisiting the history and the past events as well, which can clarify the situation appropriately. When we say schizophrenia or schizophrenia spectrum disorder, uh, if you can see, this parental diagnosis leads to higher rates of, again, psychosis. We all know it's a genetic predisposition. So if the parents are suffering from schizophrenia, the possibility of having more in the children is higher. In this, OCD represents that in OCD, 4.86 people have, again, some psychotic symptoms, and schizophrenia spectrum disorder is 3.04, which seems to be a very high percentage. So if you talk about general sense, OCD is a common symptom in lots of people who are having psychosis, or obsessional symptoms are common in psychosis or schizophrenia. How we can differentiate between an obsession and a delusion? So there are few basic points that I can tell you, but of course, it's sometimes not easy to practically implement these points into the real practice. So you have to move around a little bit from here and there. Like in obsessions, the usual themes are contamination, symmetry, exactness, forbidden thoughts, aggressive, sexual, religious, somatic thoughts, and hoarding. But delusion includes persecutory, referral, somatic, erotomania, and grandiose themes. Again, in obsession, thoughts are described as one's own, but in chronic, intractable OCD, sometimes it is difficult to see this thing. In delusion, believe that thoughts are caused by an external agency or somebody else is doing that. I'm not responsible for it. But again, there is a gray area in that too, complicated. Obsessions are associated with compulsions of cleaning, ordering, arranging, checking, and hoarding. But delusions, the repetitive behaviors may be present, which is independent of the thought content. Compulsions are usually performed in response to an obsession to reduce the distress or anxiety. But in delusion, if compulsions or repetitive behavior is present, aim is to harmonize behavior with delusional belief. So I have to be more into it, that I have to make sure that whatever my thought process is, I want to more it more firm. Yes, this is like this. This person is against me, so I will try to gather all the information and do compulsive acts to ensure that my thought is right. This person is against me. But in obsession, it is just the other way around. In obsession, conviction is absent. Maybe sometimes you feel that there is ambivalence and maybe kind of a thing. But in delusion, conviction is very strong. In obsession, excessive and unreasonable, and insight is present. But in delusion, recognized as totally justified or even as self evident, and insight is absent. So, my thoughts are right because I know that this is happening, and this is happening like this, and this person is against me. So, whatever that person does, I will have firm conviction that he is doing everything to do some harm to me and he's against me. Even if he says, I love you, that is taken as a parameter that this expression means something and he is against me. So everything goes against it. These are some of the differentiating points, but I know that there are more to it as well. Anyone wants to say anything about this? Anybody? No? No question, no query? Okay, let's go further then, move further. Characteristics of OCD related rituals and characteristic of schizophrenia related movement disorder. So in OCD related rituals, checking, washing, cleaning, touching, ordering is there. In schizophrenia related disorders, more of mannerisms and stereotypies are seen rather than checking, washing, cleaning, touching, or ordering. OCD related rituals are driven agency by or according to rules that must be applied rigidly, right? Obsession. And schizophrenia related disorders, movement disorders, are autonomous or driven by delusions and or hallucinations. So the control is delusion or hallucination in psychosis, and the control is anxiety or a specific thought in OCD ritual. Aim in OCD rituals is to reduce anxiety, but in schizophrenia or psychotic related disorders, the aim is to prove that the delusions or hallucinations are real. And usually these are purposeless. There is no meaning to it when they are doing it. In OCD related rituals, patients recognize compulsions as excessive or unreasonable. And in schizophrenia, it's absolutely lack of things there. Now, schizophrenia and OCD, as I said, it's a big overlap. In obsessional magical thinking and positive symptoms like hallucinations and delusions, there is a gray area which sometimes clinically you find it very difficult to differentiate whether this is OCD magical thinking or whether these are the positive symptoms of delusions and hallucinations. But one thing is there, the affective component. Both schizophrenia and OCD people, if the diagnosis is overlapping, there will be marked affective component into it. So they will react. So lots of psychotic people, you will see that they will cry, and then you will be confused whether this crying is because of bipolar or something else. So that crying, an affective component with the history of OCD and schizophrenia, gives more reality to us that this is schizo-obsessive with affective component very prominent and very marked. But again, if disorganized symptoms are there or again odd behaviors are there, of course, OCD is out of the question. Then again, there is an overlap between compulsive rituals and motor symptoms, stereotypy and mannerism, as I mentioned earlier. Both in psychosis and OCD, there is slowness, psychomotor retardation or psychomotor slowness or psychomotor, again, phenomena related to OCD. Schizophrenia people are slow as well, and OCD people are slow as well, and it's mostly because of the thought process generating at the back. And again, little bit of both pathological doubt and indecisiveness in OCD and ambivalence in schizophrenia. If you look at these symptoms and the boundaries, three of the symptoms, affective symptoms, slowness, and insight, will clearly demarcate what is what. So, if affective symptoms are seen, this goes more in favor of OCD and schizophrenia existing together. If slowness is there, then OCD and schizophrenia both have slowness. Insight in OCD, it's there, and in schizophrenia, it's usually not there, absent, but sometimes it can mix, but overlap is there. Negative symptoms, of course, are absolutely pathognomic of schizophrenia, and OCD. Again, we don't see negative symptoms, apathy, lack of avolition, all those negative symptoms are not seen in OCD. So these people are more energetic in that sense. Axis of disorder, at one end is schizophrenia and other end is OCD, and this is non-psychotic disorder, and schizophrenia is absolute psychotic disorder. But as you all were asking, what is the boundary where we have to demarcate the line that this is schizo-obsessive or OCD with psychotic symptoms or OCD with lack of insight or schizophrenia with obsessive symptoms. So this is again, the chart that explains that. These are the paradigms and one of the, again, what do you call, again, scale. One end OCD, other end schizophrenia. OCD with poor insight and psychotic features, but still it is OCD because we don't see psychotic symptoms as we see in schizophrenia, the delusions, hallucinations, and negative symptoms and lack of insight. Here, insight will be there. Some psychotic symptoms with poor insight will be there, but poor insight never means absent insight. In schizophrenia, insight is absolutely not there. In OCD, there is some confusion. And if you do the serial mental state examination, you will be able to understand this is not absent insight, but it is poor insight. So a little bit of the grading is there. But sometimes, again, when we are seeing patients who are partially treated by some psychiatrist who give the combination of two medication, then of course this thing is more complicated. And unfortunately, the task is more uphill and difficult for us to whether to treat this person with OCD or to treat this person with. So my point always, all along, in every presentation is before writing the medication, assess, evaluate, establish the diagnosis, only then treat. Because if you are treating and with the combination of medications in your first go, things will usually turn up worse for the patients in the longer run. Because if he goes to some other person, if he comes to me, I will be confused. Why antipsychotic medications and antidepressant medications and are given in combination? Is it bipolar? Is it psychosis with OCD? Or is it OCD with psychotic symptoms? So make a diagnosis first and then treat. Then OCD with personality problems like schizotypal or any other personality disorders, again, complicated. But usually a history is the best thing, which will be able to demarcate to us whether this is OCD with personality disorder or it's simple OCD. Now, in a schizophrenia, at one end, if the delusion, hallucination, and all the parameters of DSM-5 or ICD-11 are fulfilled, diagnosis OCD. But sometimes both of the criteria are fulfilled. Patient is having diagnostic criteria of all the schizophrenic symptoms and diagnostic criteria for all the OCD, which is, again, common. As I show you the slide, it is 4.86%, which is, again, very high confidence interval considering. Schizophrenia with OCD symptom is relatively easier. If you are not able to have a complete diagnostic criteria of OCD and schizophrenia existing together, just the obsessional symptoms, the treatment is still antipsychotic medication, and OCD symptoms do get better over the period of time. But if both the criteria are fulfilled, then of course the treatment is a combination. So if you see the ovals on the second of both end, schizophrenia with OCD and OCD with poor insight, probably the treatment strategies as far as the medication is concerned are the same, but the process is reversed. In OCD with poor insight, high dose of OCD medication, low dose of antipsychotic. In schizophrenia with OCD, high dose of antipsychotic and low dose of an anti-obsessional drug. So the treatment strategies are absolutely guided by your diagnosis in the beginning. Make the diagnosis first, then do anything else. Any questions so far? समझ आ रही है कि कुछ समझ नहीं आ रही, ये तो बता दो.
सर सब समझ आ रही है.
ओके, कंफ्यूजन हो, कोई मसला हो तो पूछ लीजिएगा, राइट? ओके, आई विल मूव फॉरवर्ड नाउ बिकॉज अगेन so many things very confusing in this.
I have a question.
Sorry.
Sir, I have one question. Like, if a person having like established diagnosis of schizophrenia and she's exhibiting symptoms of OCD but not full criteria of OCD, like obsessions about contamination, or maybe she's like fixated about some things, you know, like a fixated about her particular belongings, like कि मेरी ये चादर है तो ये मेरी होगी, कोई और इसको टच ना करे, कोई और ना ले, like in wards. So basically her main diagnosis is schizophrenia with some obsessions. Then what would be the treatment strategy for her, like?
So the primary treatment strategy, as I mentioned earlier, is schizophrenia with obsessive symptoms. Treatment is for schizophrenia. And in 80%, whatever the literature suggests, 80% of the people with obsessive symptoms, they do get better only with antipsychotic medications. This is what literature is suggestive, and clinically this is valid as well. What I have seen, if people are having diagnosis of schizophrenia with some obsessive symptoms, it can be managed without anti-obsessional medication, with only treatment for schizophrenia, and maybe add on some psychological intervention, which can help, right? So this is the reason why I'm focusing more on these things. So like algorithm for OCD in adults with schizophrenia. Now, this is when we say that both of them are existing together. This is the algorithm for both of them existing together. Like patient is fulfilling the criteria of schizophrenia and fulfilling the criteria of OCD. Then what is the treatment strategy? One, switch to amisulpiride, aripiprazole are choices due to low propensity of exacerbating OCS, obsessive compulsive symptoms. So if you diagnose a patient that this patient is suffering from schizo-obsessive, fulfilling the criteria of schizophrenia and OCD, first line of treatment, aripiprazole or amisulpiride. This may vary from one diagnostic, again, guideline to another, but mostly they agree on generally on the same. Or reduce the dose of an atypical antipsychotic. Augmentation with the mood stabilizer, preferably lamotrigine or divalproex, to reduce dose of antipsychotic. So if high dose of antipsychotic is needed for a person who is suffering from a schizo-obsessive disorder, then things will be more complicated. So you have to lower the dose of antipsychotic and add divalproex so that the augmentation strategy is utilized, or lamotrigine, rather than giving SSRIs in the beginning. But if amisulpride, aripiprazole, or lowering the dose of atypical antipsychotic and augmentation with divalproex and lamotrigine, all of them fails, which sometimes happens, of course. Then a combination of pro-obsessive SGA, second generation antipsychotics, with neutral or anti-obsessive antipsychotics, in order to reduce the clozapine dosage to minimally sufficient levels. So this strategy then changes. So comorbid psychosis and OCD initiate atypical antipsychotic plus an SSRI only if the above strategies fail. No response, change to atypical antipsychotic, SSRI, fluoxamine or clomipramine, and then see again. No response, add CBT. No response, low dose of clozapine plus an SSRI, usually escitalopram or sertraline, and if no response, ECT is the best treatment for schizo-obsessive resistant to treatment. So the treatment strategies are very simple. Initiate with aripiprazole or again amisulpride if available. If that won't respond, augment with divalproex and lamotrigine. If that won't respond, then give low dose of clozapine or add an SSRI, lowering the antipsychotic, which will not complicate the OCD, and atypical antipsychotic, fluoxamine, clomipramine, then CBT, then low dose of clozapine, and then ECT. So this is very straightforward. But what happens is, unfortunately, in day-to-day clinical practice, this is what the book says. In day-to-day clinical practice, things are a little bit complicated. So when a patient comes to us, I see OCD a lot. I don't know. I make more of the diagnosis of OCD or something, some way else. But I feel that I see OCD more than because I am able to ask the questions related to OCD. So probably the diagnosis is established. So my target is first to establish the diagnosis and then treat. So when I treated the OCDs, for example, so there was very recent one patient who was on high dose of an SSRI, OCD, pure OCD, no psychotic symptoms, but he was not responding, so I had to augment. And as you know, the augmentation strategies include adding a low dose of antipsychotic. Ideally speaking, one which won't worsen the symptoms. We tried aripiprazole, we tried olanzapine, we tried other stuff, nothing was working. We added risperidone. Now, risperidone is notorious to worsen the symptoms of OCD if the patient is psychotic. So if the diagnosis is OCD, and I will tell you why risperidone is not indicated there. So if a person is having schizophrenia with obsessive symptoms and you give risperidone, the obsessive symptoms will worsen. Here in our situation, sometimes we give an SSRI, give a low dose of an risperidone, and patients do improve. So sometimes it's tricky in clinical practice. Now, antipsychotic induce OCD. This is the phenomena which usually is seen. You have seen the patient who's suffering from schizophrenia. You gave him an antipsychotic. He gets better. His psychotic symptoms are okay, but then he starts having obsessive phenomena. Compulsions, rituals, contamination, thoughts, blah, blah. This happens because of the antipsychotic medication as well sometimes. Now, so there are 3 points, again, need to remember. Obsessive and psychotic symptoms both unresolved, switch antipsychotic. Obsessive and psychotic symptoms better, strategy will be different. Again, switch antipsychotic, things are not better, add SSRI and TCA. So this is one end. The second end, schizophrenia with treatment-induced OCD, psychotic symptoms resolved to the level that it does not influence functioning, but OCD persists, then reduce the dose of antipsychotic to minimum sufficient level or combine other antipsychotic like aripiprazole and amisulpride or mood stabilizer like lamotrigine. But if a person is having schizophrenia, you are treating them with antipsychotic, OCD or obsessive symptoms are worsening and psychosis is not resolved as well, then of course you have to resolve to other situation. In this situation, unfortunately, the most complicated situation is threatening exacerbation of psychosis occurs and OCD symptoms persist. So the treatment is sometimes complicated. In schizophrenia, schizo-obsessive, this is again test that indicated that the females are less prone to schizo-obsessive than men. Most of the people are around the age of 36, 30 plus, having both the diagnosis of schizo-obsessive. Age of onset of a schizo-obsessive is usually early 20s, not teenage, like in schizophrenia. Duration of illness is usually longer, and then the schizo-obsessive becomes complicated. Otherwise, it's better. And of course, clozapine dose is higher, needed high in schizo-obsessive, which is something around 475 to 500 milligrams per day, than only in schizophrenia. Schizophrenia, the response could come between 200 to 400 milligram, but as in SSRI in OCD, where we need high dose of SSRI, same goes for schizo-obsessive, you need high dose of clozapine to address the symptoms. Now, why these two things exist together? This is again a surprising fact that people do have this together, existing together. We know that OCD originates from the orbitofrontal cortex area around here, and it has a pathways and caudate nucleus, which is ventromedial. That's the reason why we see tics and all those motor component in OCD. And globus pallidus is involved and thalamus is involved. In schizophrenia, dorsolateral prefrontal cortex is involved. Now, dorsolateral and prefrontal cortex and orbitofrontal cortex are probably very close by. Both have caudate nucleus again involvement, globus pallidus involvement, and thalamus involvement. So in schizophrenia, it's a dopaminergic. OCD, it's a serotonergic, but the pathways, major brain areas, are practically the same except for one: orbitofrontal in OCD and dorsolateral in schizophrenia. This is one. Second complicated situation. That is the same, this slide is same as the previous one, but a little bit more, again, elaborate regarding the areas. So in schizophrenia, it's dorsomedial prefrontal. And in OCD, it's again orbitofrontal. So you have to remember that. This is complex. Anxiety, uncertainty, and goal-directed behaviors. Compulsivity with habitual behaviors. And if you look at the areas, there is a slight overlap in both the things. In OCD, orbitofrontal cortex is involved. In schizophrenia, orbitofrontal cortex is not involved. But if you look at the ventrolateral prefrontal cortex and or orbitofrontal cortex, they are overlapping with each other. So this means higher rate of comorbidity exists. Higher rate of comorbidity exists. In exam situation, I don't want my candidates to go into that debate because, again, lots of people won't be able to understand unless or until you will try to explain them in a very nice way. Even for me, explaining it to you is getting difficult because I have to cone down everything and elaborate. So sometimes it's complicated. So you have to be careful about it. OCD and autism spectrum disorders are comorbidity as well. Now, in autism spectrum disorder, psychosis, OCD, schizophrenia, OCD, and ASD, cortex, striatum, and thalamus, all of them are involved. But again, there is a glutamate, dopamine, serotonin interaction at postsynaptic level. So this is complex. Treatment-related obsessive symptoms in psychosis, worsening effects, clozapine, olanzapine. some of the studies, and beneficial effects SSRI, aripiprazole, mirtazapine, riluzole, or CBT. Now, complicated. But one thing you have to be again sure that in all these three disorders, the compulsive phenomena, if seen, it involves glutamate, dopamine, and serotonin. So you have to address all three of them if you want to really have a good outcome. Any question? Any complication? So far, I hope I am making sense. अगर मैं ना बना रहा हूं sense, please stop me. Okay. Orbitofrontal cortex and ventromedial caudate, direct pathway with globus pallidus and substantia nigra, involvement in psychosis, dopaminergic pathways. Serotonergic and glutamate pathways, OCD, dopaminergic pathways, schizophrenia. Now, pathways are the same, but the neurotransmitters are the different. So the linings or the wirings is different. So there are different wires in the same set of brain area. And those wires are carrying different currents. And those different currents are basically challenged by different neurotransmitters. And we have to correct those neurotransmitters, to correct those wires, to correct the OCD symptoms. But sometimes there is a short circuit and things do get complicated. So OCD with schizophrenia, treatment resistant and complication. And that's the reason the end outcome, best outcome for these things is ECT, because the mechanism of action of the ECT is still not as certain as we know, although lots of things are clear, but still. So a best treatment. Just having a break, sorry. मौलाना रूमी ने क्या खूबसूरत फरमाया था कि जिन बातों पर झगड़ा करके लोग मनोमट्टी तले जा सोते हैं, इन्हीं बातों पर हल्की सी मट्टी डालकर दुनिया में पुरसुकून जिंदगी गुजारी जा सकती है. सो दुनिया में अगर पुरसुकून जिंदगी गुजारनी है तो कुछ बातों पे मट्टी डाल दें. Okay, OCD in schizophrenia. Now there are two possibilities. OCS after the onset of psychosis or pre-existing OCS. So the patient was already having some obsessive compulsive traits in grade 6, 7, 8, and at 9th or 10th he developed this schizophrenia. So there are two different situations. Already existing traits or symptoms and then changing into a diagnosis, or no symptoms but gross psychosis, treatment, either drug induced or otherwise, development of the OCD symptoms. Again, very complex and complicated. एग्जाम में इस डिबेट में नहीं पढ़ना. ये डिबेट इस वक्त की है जब मैं आपको पढ़ा रहा हूं, उस वक्त की नहीं है. So this presentation is not for exam. This presentation is actually for your clinical intervention of the things to make you understand those things. Pre-existing obsessive compulsive symptoms, it could be comorbid independent OCD, right? And the treatment is augmentation with SSRI and CBT. Pre-existing OCD or obsessive compulsive symptoms could be because of the drug-induced as antipsychotic induced OCD phenomena. Then you have to optimize the dose, consider switching the neuroleptic, switch to other medications which are less problematic in OCD. Haloperidol is one of them, although I use haloperidol still in some of the patients, but I don't use it very frequently. Maybe once in a while, maybe once in a year, but not regularly because of, again, problematic side effects other than these symptoms. Autism, schizophrenia, OCD. Again, very complicated. If a person is having Asperger's, which probably won't be evident to you, and it becomes evident as well at the same time when the diagnosis of schizophrenia onset is there. Around the age of 17 to 21, you see people, young men or women with schizophrenia, and this is the same time when people bring their children to specialists, but they are having Asperger's phenomena rather than schizophrenia. And Asperger's phenomena, you are confused, this is OCD, Asperger, or schizophrenia. Most of the psychiatrists who's not familiar with this, I'm sorry to say this word psychiatrist, unfamiliar with these things, they do give treatment a combo. And when you give a combo, it's always complicated. Then you are stuck. And the job is very difficult for the next psychiatrist what to do about it. Establish the diagnosis first, then treat. Never go for it otherwise. In schizophrenia, we are know though that there is reality, confusion, and check. In autism, there are repetitive behaviors, echolalia, social reciprocity, difficulty, special interest, very fixated to alignments, very fixated to political situation, religious concepts, blah, blah, blah. And those interests are so much that they read and read and read about those things. One of my patients probably read more than 1,000 books on, again, spiritualism just because he was fixated with it and God. So he was Asperger's, not psychotic. But the parents thought that there is something wrong with him and he is psychotic. And he was treated for psychosis, but he was not psychosis actually, right? So the establishing diagnosis give you good confidence that you can take care of these individuals in the longer run. Symptoms appeared in the childhood in autism and Asperger's as well, but symptoms appear in adolescence. But unfortunately, in our social setup, people do bring their children when they are adults and they are problematic. School mein, I don't know, somehow the other, they were talking to the teachers and talking to the school authorities, and they kept on moving forward without, again, the fact that they were learning anything but any concepts. Dissociation, executive functioning, social withdrawal, increased risk of suicide, difficulty with eye contact, abnormal perception, substance abuse, self-preserving in nature, and disorganized thinking are common symptoms in both of them. Both. But unfortunately, we have to differentiate both of them because the treatment for both of them is very, very different. If you give an antipsychotic to an autistic or Asperger's person, things will worsen too much, especially risperidone. Oh, chaotic. The patient will hit the roof and you will be in trouble. Maybe if you sedate them, maybe it's different. Now, there is another complication related to all of these things. OCD, schizophrenia, and autism spectrum disorder, which is unfortunate genetics, neurodevelopments, messenger RNAs, and oxidative stresses, which leads to immune dysfunction, neuroinflammation, and microglial activation. Now, these are all very biological components. And if you start reading about microglial activation in schizophrenia and OCD and autism, it's a big Pandora box, and you will be again gone into the depth of the knowledge. But the understanding of it will give you so much insight how to manage these people well. That's the good part of it. But the bad part of it is that it's so complex that for psychiatrists like myself, I find it very difficult to understand. But anyways, we do have to understand some of the concepts. So understand the basic theme, phenomenology, and process related to it. OCD and schizophrenia, again, more difficult to treat. The outcome is compromised. The treatment outcome is compromised. More efforts, more energy, more time is needed. Prevalence in general population is, again, for OCD and schizophrenia, just a general slide, just to keep yourself into the clinical theme. Schizophrenia, 1%, OCD, 2 to 3%. Decade of age of onset, second to third, first to second. Chronic with remissions, waxes and wanes. Clinical characteristics, delusions, hallucinations, and obsessions and thoughts, blah, blah, blah. Brain region involved in OCD, as I mentioned again, orbitofrontal cortex. And schizophrenia, dorsolateral prefrontal cortex. Neurotransmitter system, serotonin primarily and dopamine secondary, and glutamate now more involved as well. In schizophrenia, dopamine primarily, serotonin secondary, and glutamate in between. So it's complex. Okay, this is just in nutshell for today's presentation. Now, if you want to ask question about schizo-obsessive, any question? अगर कोई सवाल नहीं आया तो इसका मतलब कुछ समझ नहीं आई. Anybody? No?
नहीं सर, इसका मतलब आप
आप
सब समझ आ
सॉरी,
गई।
आवाज ब्रेक हो रही है. दोबारा से बोलो.
आप कहते हैं कि या सब कुछ समझ नहीं आया या सब समझ आ गया है। वैसे
अच्छा.
सर द टॉपिक वाज कॉम्प्लेक्स, मतलब इट वाज कॉम्प्लेक्स, यस, लेकिन
It
आपने बहुत अच्छी
is
तरह
a
समझा।
very complex topic in the clinical setting as well. It is a complex topic as far as the patient's management is concerned, patient's evaluation is concerned, and intervention is concerned. And unfortunately, it gets more complicated when it is not diagnosed at the onset, half-hearted treated patients by various psychiatrists with combination of medication, things are more worsening. So now if a patient comes here, you know what to do. Diagnose, assess, and then proceed. Agreed. But this was not a question. Question है तो पूछो. No question. All well. Okay. If you feel that we have to build up the tower on this presentation, I can do that because the microglial activation glutaminergic pathways, glutamate pathways, and neurochemistry involved in OCD and schizo-obsessive, I haven't covered that. That is again a tricky topic, but it helps you in management significantly if you'll be able to understand. We can build that up. Otherwise, next topic will be opioid agonists.
Assalamu alaikum, sir. I have one more question about schizo-obsessive. So, is it possible that like I recently I'm seeing a patient with schizophrenia and prominent obsessive symptoms, and she's like very difficult to treat, and she has been like she has been diagnosed with schizophrenia for like 10, 15 years, and she was treated on different antipsychotics. But the problem is like even her psychosis is not setting. Like she was treated on mainly typical antipsychotics and also on olanzapine. But when I started her on low dose and clozapine, so she developed like confusion.
Was
So
clozapine prescribed with other antipsychotics, or again, all antipsychotics were tapered off before starting clozapine?
so she was like obviously she was not on any other antipsychotic at that moment. Maybe there is some component of antipsychotic remain in her body. Like she was on depot, but that been like 20, 25 days ago the last depot was given to her.
The depot injections do have sustainable effects up to 6 weeks to 3 months.
3 months. Okay.
6 weeks to 3 months. And in presence of another antipsychotic, when you start clozapine, the dose escalation is slow. So what I do is that I push up the clozapine 12.5 milligrams every fourth day. So it will be 25 to 50 milligrams per week. If there is no problem, otherwise I push up the clozapine dose 100 milligrams per week. So I have to cut down the dose escalation of, again, clozapine from 100 milligrams per week to 50 milligrams per week, considering this situation. However, in the beginning, even if there is a confusion, and confusion is not related to some organic pathology, I will keep pushing up the clozapine if the blood picture is safe. Because sometimes the confusion comes with the psychiatric morbidity as well. So those delusions, hallucinations, which were suppressed by the typical antipsychotic, start propping up, and there was a confusion. So you have to understand whether this confusion is organic in nature or psychological in nature.
So
If
yeah, so
psychological in nature, don't worry. If organic in nature, then take care of the stuff, delirium.
Okay. Right. Maybe it was because of, like, as you said, like, typical antipsychotic might be in her body, in her system as well, at that time. So,
Number of possibilities, but if the blood picture was okay and she is not in acute confusional state like delirium, don't stop clozapine. Keep pushing it up, and at least take it to 200 to 300 milligrams per day. This is
okay.
another problem, unfortunately, which happens clinically. We are so afraid of clozapine that we don't want to prescribe clozapine, but clozapine is a wonderful drug. I have more than 200 people on clozapine, and the people who works around me, they know that the outcome is miraculous. The
True.
disease, what was not better in years, was better in months. Outcome with clozapine is marvelous if it clicks, of course, just like any other drug. And in majority of the situation, if people have tried 3 or 4 antipsychotics and we started clozapine, it worked very well. So the quality of life improved, the symptoms improve, the general well-being is improved, right?
Okay. Right.
Good.